Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning and Obesity Canada. My name is Denise Campbell-Scherer. I am the Associate Dean for the Office of Lifelong Learning, as well as a family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new Clinical Practice Guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity, and the result of more than 2 years of hard work. We acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. We are very pleased to have Dr. Leen Naji here today to present on emerging technologies and virtual medicine in obesity management. Dr. Leen Naji is a graduate from the McMaster University Medical School and Family Medicine residency programs. She practices in Ontario as a hospitalist at Milton District Hospital and is an addiction medicine physician at Hamilton RAAM Clinic. She is a clinician scientist with a particular interest in research methods, clinical epidemiology, and guideline development. She is currently completing her master's degree part-time in the Health Research Methodology program at McMaster.
It is a great pleasure to have the opportunity today to review with you our guidelines on the use of technology in the management of obesity. I am here today on behalf of my co-authors, Dr. Rick Titus and Dr. Dennis DiValentino. The title of our chapter is Emerging Technologies and Virtual Medicine in Obesity Management, which is an important topic now more than ever during the COVID-19 pandemic. I'm going to start off by providing some background information about what we mean by technology and how it can be used in obesity management. We'll then go a little more into the research about the evidence available, the recommendations we've derived based on this evidence, as well as some of the limitations and areas requiring further research. We'll end off with a summary and key messages for healthcare professionals and patients living with obesity. So first off, I want to define some of the terms I'm going to be using throughout this presentation and that we use throughout the guideline as well. We refer to 3 different modalities for the management of obesity: conventional care, usual care, and technology-based interventions. Whenever we're talking about usual care, we're essentially referring to passive rather than active management of obesity. So this includes anything from no interventions to brief opportunistic interventions such as counseling and nutrition advice provided by a primary care provider, for example, to their patient during a visit for, let's say, a urinary tract infection. So it was not intentional intervention. Conventional management is more of active management of obesity. This includes scheduled face-to-face counseling and education sessions surrounding nutrition, exercise, and weight. Lastly, technology-based interventions, as the name would imply, include the use of some type of technology in the care, like a mobile device or a web-based platform. This is the focus of our current chapter. So just to recap, usual care is passive, opportunistic, brief interventions. Conventional care is active, dedicated sessions for counseling and education regarding nutrition and obesity, whereas technology-based interventions is the incorporation of technological means into the conventional-based strategy. Usual care is often used as a control group in many of the trials. For many years, conventional care has been the go-to. There is considerable evidence proving it to be effective in achieving weight reduction in patients with obesity, as well as reduction in waist circumference for up to 12 months, which is pretty much as far as the trials have studied. We observed benefit in not only weight reduction, but surrogate markers of cardiovascular health, including blood pressure and serum cholesterol levels. Obviously, this is labor and time intensive and may be difficult to execute. Unfortunately, making the programs less intensive by reducing the frequency of encounters, for example, has been shown to negatively impact outcomes. So we're seeing that the more intensive the conventional care, or the more frequent or longer the counseling sessions, the more the benefits. One study by Wadden et al. Published in the New England Journal of Medicine compared patients receiving the same pharmacological therapy for obesity and intensive counseling versus brief interventions and found about double the amount of weight loss and 4 to 5 times the drop in systolic blood pressure in the intensive compared to the brief intervention group. So they have two groups, both of them receiving a pharmacological therapy for obesity management. One of the groups, in addition to the pharmacological therapy, had an intensive counseling schedule, whereas the other one had briefer interventions, or briefer counseling, I should say. And they found that the one with the intensive counseling had 12 kilograms of weight loss at 1 year compared to 7 kilograms in the other group. And the intensive group had about a 4 to 5 point drop in their systolic blood pressure at 1 year compared to a 0 to 1 point drop in the less intensive group. And this is quite remarkable because most of the trials in obesity are unfortunately comparing an intervention to no intervention or usual care, as I mentioned before. So this is one of the few studies that actually had an active comparator group. Now, part of the challenge with conventional therapy is feasibility. How can we maintain the benefits of conventional care programming on a long-term basis? And this would also be applicable during times like these with the COVID-19 pandemic. How can we deliver effective care for patients living with obesity when we're not able to see them or have as much contact with them? The use of technology in healthcare administration has repeatedly been shown to be cheaper and more efficient in the long run. In the case of obesity management, it may cut back on the time and resources that would otherwise be required by clinical staff in administering conventional care. Many family physicians also report feeling ill-equipped to deliver high-quality counseling or brief interventions for obesity, which is a barrier that may also be overcome with technology. The increased availability, accessibility, and affordability of technology renders this a potentially feasible option and quite appealing for patients given the flexibility and portability of these options. According to Canadian statistics as of 2019, over 90% of Canadians have a mobile phone and 89% of households have an internet subscription. So we wanted to provide some recommendations about the potential for incorporating this technology in the care of patients with obesity. And of course, during these unprecedented times and the COVID-19 pandemic, virtual care has come in demand more than ever. The questions we're hoping to answer are, how can we supplement usual and conventional care with technology to provide effective care for patients with obesity? What parts of conventional care may be replaced by technology, possibly offering a more convenient and cost-effective treatment for both the patient and provider? Lastly, what kind of technology is actually effective? There are quite a variety of technology-based strategies employed by these studies, and we chose to group them into three categories: web-based platforms, mobile devices, and wearable tracking devices. Web-based platforms is essentially providing online resources through links and CDs to weight reduction programs, meal plans, and exercise plans. This could also include self-monitoring diaries and entries of intake and exercise, as well as goal setting. Mobile device-based interventions include text message reminders or educational information, as well as tracking applications for exercise, weight, and food diaries. Examples of individualizing this intervention would be things like text messages that positively reinforce exercise or healthy dieting or healthy entries, or even weight loss for weight loss tracking applications. Wearable tracking devices are like pedometers, which in this day and age would be our Fitbits and Apple Watches. So far, the evidence looks quite promising. We've seen that by combining technology with conventional care, we get superior outcomes to either one alone, or of course, to usual care, which we said earlier is just passive care. And while studies haven't investigated the effectiveness of activity trackers alone, we've seen that by adding it to a treatment regimen, we are able to improve outcomes of weight loss. A systematic review of 25 studies found that 20 of these studies reported higher weight loss in the group of patients wearing the tracking device compared to those who weren't, when it was combined with conventional care. The outcomes are even better when the program is tailored to the individual or more personalized. This could be individualized with one-on-one counseling or personalized real-time feedback and notifications using technology means. This could be as simple as tailored meal plans or activity recommendations. We have seen that the evidence about replacing in-person conventional care with technology, however, remains inconclusive with one meta-analysis of 23 RCTs showing that it is not effective and inferior to conventional care alone. Again, this shows the importance of studying these interventions against conventional care rather than usual care or weightless controls, which is what is done in most of the studies. And this really brings me into the limitations of the research in this field, which I think are important to discuss when interpreting these recommendations. This is a relatively new field of study and one that hasn't been as developed or as rigorous from a method standpoint. One of the major limitations is that most studies are evaluating technological interventions compared to no interventions or usual care, which we said earlier is just passive care. Obviously, it is much less difficult to find an effect here. Really, what we want to compare is technology-based care with or without conventional care to conventional care. We want to see whether we can replace or improve what we are currently considering to be the standard of care. And if all we do is compare one technology-based treatment to no treatment, then we certainly would not be able to do that. Another limitation is that a lot of these studies have looked at a combination of different technology-based interventions, all of which have multiple dimensions in and of themselves, making it difficult to really decipher what intervention and what component of that intervention is actually effective. For example, many studies have combined web-based platforms with mobile-based apps or mobile apps and pedometers, for example. In order for us to really know what works, we need to study these interventions in isolation. Another limitation is the somewhat short timeline of these studies. The follow-up periods of the studies range from 6 weeks to 6 months. One of the main issues we have seen with conventional care is that while weight loss does happen initially, it is not always sustainable. So the effectiveness of obesity-based interventions is often stratified into the immediate weight loss and long-term maintenance phase. When we're studying technology-based interventions, we need more studies with longer follow-up to evaluate the long-term weight maintenance implications. Another major limitation is the external validity of these studies. A lot of studies have excluded patients with comorbid or chronic conditions such as diabetes and hypertension. I think anyone listening to this talk knows very well how well these conditions are interrelated or associated, and therefore how important it is that we study obesity within this population. Certainly, as with any new intervention, we try to study it in an ideal setting before studying it in a pragmatic one. But the hope here is that future research shifts to study obesity in a more pragmatic population. In summary, we've seen that there is some evidence to support the use of technology for obesity management with or without conventional care, but no evidence to support using it as a substitute for conventional care when it would otherwise be an option, or I should say inconclusive evidence. There's evidence to support the inclusion of personalized or tailored interventions within technology-based care, such as individualized treatment programs or feedback. And more research is needed to really understand which technology-based interventions are actually effective specifically. Is it the web-based strategies? Is it the mobile device? Is it the tracking apps? Or is it the tracking devices? Based on everything we discussed, our recommendations are as follows. Number 1, implementation of management strategies can be delivered through web-based platforms like online education on medical nutrition therapy and physical activity, or mobile devices like daily weight reporting through a smartphone application in the management of obesity. We suggest that healthcare providers incorporate individualized feedback and follow-up, like personalized coaching or feedback via phone or email, into technology-based management strategies to improve weight loss outcome. And the use of wearable activity tracking technology should be used as part of a comprehensive strategy for weight loss. And the last thing, which is not a formal recommendation due to the inconclusive evidence, but I feel the need to reiterate, is that we aren't saying to replace conventional care with technology-based interventions, but to potentially offer it when conventional care is not available, less feasible, or not preferable by the patient. Or, of course, to add it on to the conventional care program. But we need more research to see whether it may be effective to replace conventional care programs with technology-based interventions. This is really just reiterating the recommendations and summary of evidence which we just discussed. So our key messages for healthcare professionals are obviously the recommendations that we just made. And as we discuss, we need more studies comparing the technology-based interventions to the current, gold standards or standard of care, which is conventional one-on-one counseling or group therapy, for example. In terms of our key message for people living with obesity, our message is to essentially consider for patients to consider speaking to their healthcare provider about which technology-based intervention may be right for them and how these may be incorporated into their treatment program. In many cases, conventional care may not be an option due to limitation of resources or patient schedules, making this an even more attractive option for them. And that's the end. I want to thank you all for listening and to please use this link to access our full chapter as well as the rest of the guideline if you're interested in reading it in more details. Thank you.
Thank you so much, Leen. I think we've got some additional remarks now. We're going to pivot to Obesity Canada to learn a little bit about how they're using technology with the Obesity Connect and Obesity Connect Pro. So I'd like to introduce Dawn Hatnaka, who's the Executive Director of Obesity Canada. Her graduate work at McMaster University in Medical Anthropology and post-degree diploma in adult education has helped her with a broad perspective. She has served on numerous national and international medical education committees, and her special interest has been the next generation of obesity researchers and clinicians, which are the Student and New Professional SNP program, to help advance the understanding and acceptance of obesity as a chronic disease. And I just also want to reiterate that the guidelines would not have happened without Dawn's patience, good humor, ability to wrangle cats in zero gravity. So welcome, Dawn. We're really looking forward to hearing a little bit about the use of technology in the implementation of these guidelines.
Thanks very much, Denise, for that very generous introduction. One thing I just wanted to, you can see on the slide on the presentation right now. So a couple of years ago, we noted in our communities that we needed some different places for networks for some of our members to be able to connect in a way that was meaningful and secure. So we actually have two different communities. So the one you see on the screen right now is OC Connect Pro, and this is actually for healthcare professionals working in the obesity space. And what it is basically a place where you can go, you can start discussion groups. There's discussion groups that are already happening, but it's for healthcare providers to learn, share information all about obesity care. And as you can imagine, this started with the launch of the clinical practice guidelines, but shortly thereafter, with the pandemic and everything that's happened, this has become quite a vibrant place. So I know a lot of healthcare practitioners have had to transition and be very nimble, changing what they've done and from what they've to things that are not necessarily really familiar to them, but everybody's had to go through this very difficult change. But I think it's also produced a lot of opportunities. So this is a place where a lot of the community has been talking about things that have worked, things that haven't worked, and kind of what we see might be happening for the future. There's so many different changes that we've gone through, and I think we're all trying to do our best under somewhat difficult circumstances, but this is one of the communities that is where we're trying to help support each other. The other community is actually very similar sounding name. It's OC Connect, but it's another safe place. So this is actually for the patient community or people living with obesity. Obesity Canada's always had a very strong presence in social media, but we noted, and we've had several focus groups with people living with obesity, that that really needed a separate place. So this is again a safe, secure place where people living with obesity, affected by obesity, can go and have a community of support. They can access evidence-based information and engage with each other and really talk about the issues that matter to them. Sometimes it might be, just having somebody supportive to talk to, or maybe just sharing an idea. But when you have we just found that when you have an open network where anybody can comment, anybody can participate, that there's lots of great people out there, but there's lots of, I call them internet trolls, people that want to point out the negative and not necessarily be supportive. So this is a place for patients. So some of our clinicians have been promoting this space, and this has actually been growing exponentially since we opened it up for those living with obesity. So this is a moderated, hosted space with leaders in the patient field who kind of create content, offer opportunities, and actually there's a town hall every month for people living with obesity to kind of talk about what matters to them and have a little bit of interaction, especially in this very secluded and I guess individual time that we're living in right now, where we're all kind of, not all of us, but a lot of our provinces are in lockdowns, or particular areas are in lockdowns, and we can't necessarily get out and about and engage in the ways that we might want to. So I don't know if we want to go to questions now, or I know.
Yeah, that sounds great. I think I would just like to introduce Dr. Sharma, who's joining us for the panel as well. So Arya was recruited from Humboldt University Berlin in 2002 to a Canadian Research Chair in Cardiovascular Obesity Management at McMaster in 2007. He then moved to Alberta to be Professor and Chair of Obesity Research and Management and co-director of the Provincial Obesity Program. And in 2005, he spearheaded the launch of Obesity Canada. So delighted to have Arya joining us with the panel today. And I think we can open it up to some questions, because I think this is such an emerging area. And we have one question already. And just to remind all the colleagues that the Q&A box is in the black bar at the bottom of your screen on the right. But Stephanie is kicking us off, wondering about, regarding this recommendation, the implementation management strategies can be delivered through web-based platforms. So online education on medical nutrition and therapy and physical activity, or mobile devices. For example, daily weight monitoring through smartphone application and the management of obesity. And Stephanie's asking a very astute question of, would we ever recommend someone weigh themselves daily? So that's actually a really good comment and question. So does anyone want to respond to that question from Stephanie?
Well, it's Arya here. Hi, Denise. I think maybe I can take this one. So believe it or not, there actually is a randomized controlled trial on exactly this issue of weighing daily or not weighing daily. And this was published in the New England Journal. I think, well, it's been a while since it was published. But what it actually showed is that people who weigh themselves daily are much less likely to gain weight than people who don't. Now, having said that, so there is evidence from an RCT that actually shows the benefit of weighing daily. But now anybody who's in practice and anybody who's read the guidelines knows, we're trying to take away the focus from weight, and B, that we always have patients who will simply not do well with daily monitoring. And this is not just with daily monitoring of body weight. This is also true for other kinds of daily monitoring. So I can remember that, that there are patients who, if you get them to measure their blood pressures every day, they're going to have all kinds of questions. And in fact, they'll end up measuring their blood pressure several times a day. And then we all know the patients who then, show up with Excel spreadsheets where there's, hundreds of recordings, and they'll have tons of questions about those. So you have to be very careful about who are you recommending this for, where are you recommending this, and what is it being recommended for. So I would absolutely agree with the questioner that this is not a routine recommendation. I mean, we would certainly not recommend that every patient weighs themselves every day, but there will be patients who find this helpful. I generally, sometimes I don't recommend patients weigh themselves at all. But for those who do, you definitely also want to have a conversation about the daily fluctuations in weight gain, because those are not, that's usually fluid retention or fluid fluctuations that happen from one day to the next, or even just from the morning going to the evening. If there's a change in body weight, that's not body fat, that's body water that's changing. And so, you have to really educate patients on what these numbers mean and how these numbers can be used. And what you're ultimately, of course, looking for are trends and not fluctuations from day to day.
Mm-hmm. Yeah, and I'm just going to ask a question of the panel so far. I think, Dawn alluded to it, but COVID has been so very, very challenging on our patients. And really is, a lot of people have been struggling with mental health concerns and addictions. And Leen, I know that's your area. And I'm just wondering about your clinical experience as it relates to this virtual pivot. I think we've had a large real world experience this last 10 months or so on this virtual pivot. And perhaps Leen, Ara, you could comment on how you found that, how your colleagues have found it, any pearls or tips or best practices you've come across.
Yeah, I mean, I think it definitely makes things really difficult, because for a lot of these things, obesity, but also, like you mentioned, I do a lot of addictions work. The human interaction is a huge part of the therapy. But I think at the same time, it's kind of made us a little bit more available as well, because patients can contact us on short notice and at times when they otherwise would have not really been able to, when the appointments were in person. But I do think most of the research is pointing towards kind of more negative outcomes. And I don't know how, Arya, you're kind of dealing with that from managing an obesity perspective.
Yeah, I mean, I'd echo your statement, because I think there are some huge advantages of having the virtual visits, especially for our patient population, where, coming to a clinic, apart from just the geographic distance, very often for patients having to drive for hours to come to the clinic, for a 5 or 10 minute appointment, which doesn't really make a lot of sense. You have to pay for parking, you have to navigate, the whole issue of going to the clinic for a very short follow-up visit, which might really be an interaction that just takes a few minutes. So that has actually made things a lot more efficient. So what I've noticed with my patients is I'm able to see them at much shorter intervals. So rather than seeing them every couple of months, I can now actually see them every couple of weeks, because it's just a quick phone call to check in and see how they're doing and if there's any questions or problems. So that aspect has certainly improved, and I don't see it going away. I think we are going to actually see those kind of virtual visits happening in the system going forward. This, of course, is much more difficult when you're seeing someone for the first time, or in fact, when you're not even seeing someone just because you're on the phone. So I think for an initial consult, when you're first seeing the patient who you've never seen before, and you're having a first conversation, about sensitive issues, etc., you do want to see the patient. You want to see the body language. On occasion, you might actually even have to do a physical exam on the patient. So, that of course is all very difficult when you do it virtually. But doing it virtually in terms of follow-up visits, certainly there's a huge advantage of doing that. And I think we're quite comfortable doing that by now.
Mm-hmm. Yeah, I certainly echo that as well in the primary care space, that, in people with whom you've had a longstanding longitudinal relationship, it's very efficient and quite appropriate to do virtual follow-ups for certain things, provided you don't need to examine them. But in the absence of relationship, and particularly if you can't see the person, if it's telephone, you lose an awful lot of clinical information about what might be going on with the person. So I think there's a lot of work to be done in the virtual space. Nicole has a follow-up question here around What supports can be provided to Canadians living with obesity so they can take best advantage of digital health resources and virtual care options? Um, and that's an interesting issue. Is this trend towards virtual going to worsen inequality? So I'm just curious, Leen, in your work, have you come across that there's a differential in terms of people's ability to be able to interact?
That's an excellent question. I actually didn't come across that in my research, but the one thing I will say is, these technology-based interventions can be expensive when, if it includes like a pedometer or a tracking device or something like that. But a lot of the interventions are also just kind of web-based strategies. It could be things as simple as email check-ins by like a healthcare provider or even an automated one. And I think I showed some of the stats earlier where the majority of Canadians at this point do have access to internet at home. And so it, hopefully is accessible for a lot of people in some form or another. But I think definitely for people who don't have access, that would be an issue. And I don't think there was any research that we came across to kind of specifically look at this.
Mm-hmm. Aria, have you encountered any difficulties with people being able to interact with the clinic?
Not really. I mean, I think when we started out on this, there was a steep learning curve. Uh, People were just getting used to getting on the Zoom calls or getting on even just the phone calls. So scheduling was, a bit of an issue, and just getting at that comfort level. But I think most people have now gotten used to it. Uh, I know that I and my colleagues have certainly gotten used to doing it. And there's a different tone, there's a different language. You have to, uh, some things might just take more time, but that's fine. It's still, I think, uh, the ease of execution makes it much more attractive. And especially in Alberta, you are dealing with long physical distances. It's not rare to have patients driving 2 or 3 hours to come and see you. And this makes this a lot easier, and actually lowers the barriers for care, which I think then outweighs some of the drawbacks. And as people get more comfortable using this technology, I think we can continue improving and making sure that we meet all the quality standards that we've gotten used to when we do face-to-face visits.
Mm-hmm. Yeah, I
I
do
would
want
agree with
to. Go ahead, Lee.
Oh, I was just going to say, I would agree with Arya that, when people have to come into clinic, there's that opportunity cost of having to miss work and the travel costs. And when it comes to kind of trying to reach them virtually, it can definitely be challenging to find a way to do that. But certainly if we have a way, it tends to be cheaper. I know with our addictions practice, we have a lot of people in shelters, and we just tend to kind of contact the shelter to get a hold of our patients because they don't necessarily have access themselves. So I think at the end, it probably does increase accessibility.
Yeah. But to Leen's point, there's also some disadvantage because, usually when you have a clinic visit, people, they prepare for the clinic visit. They have a list of questions they want to ask, and they prepare for it even mentally, and they're not distracted. What sometimes happens now with virtual visits is that, you're reaching the patient while they're driving a car, or while they're while they're out grocery shopping, or while they're at work, and sometimes they might not actually be in the state of mind or even have the privacy around themselves to really have a proper visit. So that can certainly be a drawback, and we've had to reschedule some conversations just because the setting was not appropriate, and that's certainly a downside. So I think that again, as we start getting used to doing this, we will learn, and things will hopefully get better. So that's certainly something, a downside of virtual visits that I've experienced is that sometimes it's almost like you're interrupting something a patient is doing, because in some cases they've even forgotten that they were booked for the call, and so they're right in the middle of doing something else when you call them, and that certainly is not ideal.
Yeah, I'm going to share. We've been working on a project since the pandemic hit, looking at vulnerable individuals in ethnocultural communities. We'd been working on that prior to COVID around determinants of health for obesity and diabetes, and live realities of people. And one of the things we learned in the COVID pivot is that people are incredibly creative in terms of how they actually make the system work for them. And so, for example, we have stories of using some of our community health worker cultural brokers in the community where they would actually take people to visits. And the way that they're actually managing it now is the patient is showing pictures on their phone of the hallway signs in the hospital so that a person who can't be with them can help them navigate to know where to go. And we have certainly extensive data about the technological divide in terms of people not having internet access, not having devices. And so that making it very challenging for children to access school and for people to access other supports. And then again, with translation, prior to COVID, people would have signed consent to have someone with them to provide certain kinds of translation. And now that's having to pivot to the virtual environment, but still signed personal consent is being required, which is a barrier. So, so I think I really appreciate Nicole's question, because I think as we sort of transition into this space, the expression I heard was COVID-19 is a storm, but everybody's in their own boat. I really appreciated that, because I think the lived reality of different people and how they can then access care is quite different. And so while there's many boons and great things that could come with this, there's also things we have to think through so that we make sure that no one's left out of being able to access care. So just pivoting then a little bit in terms of all the reading, I know we don't specifically in the guidelines endorse any platforms, Leen, but clinically, you know, in your own work, or in Aria, in your work, or in the Obesity Connect dialogue, has there been anything identified that's been particularly useful? You know, anything where if there was someone who felt that this would be something they might like to add in their practice, where you'd feel comfortable to have direct a patient to some sorts of services?
So I can talk from the evidence standpoint. I'll let Arya kind of talk about his clinical experience. From the research standpoint, actually, most of the research that shows a positive kind of outcomes is the tracking devices. So things like the wearable activity trackers were the ones that we saw most reliably lead to positive outcomes. And that's, I think, the only recommendations that we made that was a strong recommendation. And then the other thing was kind of individualizing that. So I think that one of the issues with technological kind of interventions is that they can be very vague and feel not personal. So if you just kind of give someone access to a link or an app that doesn't seem to be kind of, you know, talking to them, they may not connect with it as much. And so adding in some form of individualization, whether that be through a phone call or a personal email, or some of these studies, what they did was kind of having these notifications that pop up if somebody kind of reaches a milestone. So those kinds of things were found to kind of positively influence outcomes. Arya probably has a lot more experience in terms of clinically what he's seen.
Well, I mean, there are certain, I mean, there certainly are some platforms out there that seem to be more popular than others. But I would also say that individual preference is a huge issue. I mean, there are some people who just find certain platforms and certain programs or certain apps much more helpful than others. You know, and it's very hard to say why. You know, is it the appeal? Is it the language? Is it the ease of operation? Is it the time that it takes to actually get to know the app and work with it? The more features an app offers, the more complicated, obviously, it is to operate. And so sometimes less is more. There's also differences between paid and non-paid versions. So there's a lot of these apps that you can download. You know, you can download platforms that are basically free. But then if you want any of the extra features, you're going to have to pay for it, and there's a subscription cost to that. So you kind of leave it up to the individual. I think it's more about what it is that you want the patient to do with the app. So if you know, if the emphasis is going to be on activity tracking, well, then that's, you know, that's a different type of thing. Or if it's food tracking, well, that's a different thing. There are some apps out there that actually give you psychological support, right, or motivational support, etc. So that's, again, that's a different thing. So I think you have to sort of think about where is what is it that the patient would actually benefit from? Sometimes it might just be a mindfulness app or a relaxation app or an app that helps patients sleep better. So it really depends what the patient wants. And in each of these categories, there's probably, there's an increasing number of platforms out there. And the general recommendation is, I can say is, some of my patients have used, platform A, B, or C, but you have to try it out for yourself and see which one suits you best. And it's, just because something works great for one person, it might not work at all for someone else.
Mm-hmm. What do you find about people's preferences as far as journaling goes, Arya? So certainly there's some evidence, but it's a tough thing for people to do.
Well, well, first of all, some people find journaling extremely tedious and just can't get themselves to do it, right? Journaling, especially if you want to keep it up for every day and doing it with a level of detail, is actual work, right? And doing this day after day after day is just extremely tedious, and it's very hard for a lot of people to see an immediate benefit. Now, some people do see the benefit and say, yes, I see the benefit, and this really helps me, and I love doing it, and I've gotten used to it, and it's become part of my routine. But for a lot of patients, they struggle. It's not part of their routine. They kind of have to force themselves every day to do it. And it's just not a lot of fun, right? And it really takes up time if you want to do it properly and accurately. So journaling is definitely not for everyone, and I pretty much leave it up to the patient on how they want to do it. I mean, I'm happy when people do, if they want to do pen and paper and journal, I'm fine with that. If they just want to take pictures and photographs, that's fine. What I'm after in the journal is not so much the precision, but the act of getting that feedback, right? So it's the ongoing feedback of what's actually going on that is helpful. Now, there might be other people who have other views on this, or might be using this for other purposes. But I think it's virtually impossible to get somebody to do tracking if they are really not interested and they can't do it, and it's tedious and it's not helping them. It's frustrating and it's not helpful. So it's definitely not for everyone.
Mm-hmm. Arya, how do you handle the conversation with your patients around, in a lot of these platforms, they have calculators around, you should be losing this many calories or this many pounds per week, or calculators in terms of what they should be eating, etc. When we know that type of thing has got a lot more complexity to it than is actually conveyed in most of those tools.
Yeah, I mean, and what's even worse is that some of those calculators or some of those platforms will actually celebrate when you achieve a weight loss milestone. It'll actually send you positive messages, but that is actually kind of the opposite of what we are trying to do. We are trying to get patients not to focus on weight, and then these apps will actually be all about weight and all about weight management, and they'll be all about weight loss curves and sending reinforcing messages that kind of work against the actual principle. So again, you probably have to educate the patient and tell them what part of the app, or why, first of all, why are they using the app? What's the point? And what are perhaps the messages that need to be ignored? So you're absolutely right. I mean, some of those apps are not very helpful. I mean, they might be helpful for other things, but they're certainly not helpful if those are the messages that are being sent.
Mm-hmm. Yeah, I find them quite helpful for people to be able to track and look a little bit at their nutrition.
Absolutely.
But which can be really helpful. How much fiber are they actually getting? Those kinds of things. But I am really apprehensive around them then perseverating around, am I within my target, and am I losing the right amount of weight, for all the complex physiology. So if people are interested, have a look at the Science of Obesity chapter in the guidelines, which goes into this in a great deal of detail and really explains why this is so heterogeneous for so many people. And you'll have patients who are, quotes, doing everything right and really staying quite weight stable and perhaps not losing much weight at all. And the last thing in the world we want them to do is get discouraged with that. So that's just sort of maybe a little bit of a thing that I hope, as we get more and more of this technology, we'll have more actual evidence-based apps that actually encourage that put some of the actual evidence in those pieces. Have you seen anything like that yet, Aria? Anything really good? I haven't.
Not really, but I must admit that I don't spend a lot of time examining these apps, right? I mean, most of the in our clinic, actually, most of the recommendations come from the dietitians, and they have certain apps that they like to recommend or that most of their patients do well with. I kind of leave it to the patient. I suggest that they go out and do the work by themselves to find out if there's an app out there that might benefit them. But I generally do not recommend specific apps simply because I personally have not spent enough time, looking at all the different platforms that are out there.
No, and I must admit, I think there might be a generational gap. I have not either. So, Leen, did you come across anything in the work that you did for the writing of the chapter?
No, a lot of the studies kind of designed their own applications or web-based platforms that they kind of studied. So they didn't really use ones that are usually like available to us. But a lot of the themes in terms of the tracking, the mobile phone tracking apps were kind of tracking food diaries. So like you guys mentioned, whether it be like photos or the actual nutrition facts, and then exercise and weight or cardiovascular kind of like lipid profile and things like that. So just tracking things for people to trend their progress.
Mm-hmm. Dawn, can you just briefly comment? Oh, is she still there? Maybe she's zipped away.
Sorry, Dawn had to.
Oh, thanks, Nicole. Nicole, I was just wondering if you could just chime in a little bit about the Certified Bariatric Educator course.
Sure. So we're actually revamping it right now to reflect the new guidelines. So we should hopefully, I'm hoping in the next couple months, have that available. That will consist of the four sections and 200 questions. The prerequisite for the Certified Bariatric Educator exam and designation is the Advancing Obesity Management Program. And that one, we are actually going to be launching the first 3 modules, hopefully this week. So we can keep an eye out. I'll be announcing that on the OC Connect Pro network. And again, that's 10 modules, and that'll really dive into the guidelines.
Mm-hmm. Oh, that'll be really exciting. Mm-hmm. Well, and so, sorry, go ahead, Aria.
No, I'm good.
Okay. I just want to give our attendees the opportunity for a last word. So if anybody has any thoughts or questions or tips, please chime in the Q&A. And also just really encourage folks. I mean, I think a great venue for a lot of these conversations is the OC Connect Pro, because, there's so much stuff expanding constantly in this area. That, how many people are in there now, Nicole? It must be at least 500 or plus, right?
Actually,
it's 1,200.
1,200?
Yeah.
Good grief.
That's a lot of people.
Okay. Yeah, it's expanded dramatically. And so, it's a great way to crowdsource some of these questions. So if you have somebody and you're looking for a particular item or a particular app, you can definitely ping the crowd, and within that whole group there's an enormous amount of shared knowledge, and and people are quite keen and quite active as well in the environment. Okay, so Leen, thanks ever so much for taking time and for all the great work that you did on the chapter. And one thing that's exciting about these guidelines to all of us is that they're a living guideline, and so as new research comes down the pipe and new things are published, the vision is to keep those chapters updated. And I suspect over time, this is going to be one that's going to be really dynamic and sort of change as we learn more things.